Hello and welcome to this video, Lobular Carcinoma in situ. So first, let's understand what is lobular carcinoma in situ. First of all, note that this is a non-invasive cancer that is originating from lobules of the breast. As you know, the lobules in the breast are responsible for production of the milk. And in this picture, you can see the structure of different lobules and a little bit of ductal system. So we have lobular acinus, we have different types of lobules here that are responsible for production of the milk, and they use the ductal system in order to transfer the produced milk from lobules to the ducts and then to the nipple. So in case of lobular carcinoma in situ, we have cancer cells that are confined within the lobules of the breast, and they have not invaded the basement membrane of the lobules, and they have not reached to the extralobular stroma. And this is what makes the difference between lobular carcinoma in situ and invasive lobular carcinoma. Another point is that, of course, this is not a true cancer. This is not categorized as a true cancer, but because of the fact that we have potential for conversion of the lobular carcinoma in situ to the invasive lobular carcinoma or even invasive ductal carcinoma, this cancer is associated with higher risk for malignancy. And it is happening in premenopausal women, and the peak age for diagnosis of this cancer is between 40 and 50 years of age. So here in this picture, you can see the different parts of the breast. You can see the fat pads that are surrounding the lobules and ductal system. Here we have lobules that are responsible for production of the milk, and we have ducts that are responsible for transferring the milk from the lobules to the nipples, and also in between we have lactiferous sinuses that milk passes through and at the end reaches the nipple. So here in this picture, you can see a structure of one lobule in the breast. So as you can see, it is surrounded by arteries and veins, and it also has a secretory epithelium. This is the innermost lining of lobules. We have also myoepithelial cells that are surrounding the secretory epithelium. Secretory epithelium is responsible for production of the milk. Myoepithelial cells are having more of a supportive role, and surrounding that, which is not shown in this picture, we have basement membrane which is supporting the whole structure. So again, in case of lobular carcinoma in situ, the cancer cells that are mostly coming from secretory epithelial cells have not invaded the basement membrane, and they have not reached the stroma of the breast. And this is a schematic picture that you can see, and this is actually explaining what are the different types of cancer and what are the origins of different types of cancer. So we have lobules here, we have also ducts. So as the result, we have lobular carcinoma in situ, which is coming from lobules, but they have not invaded the basement membrane. We have ductal carcinoma in situ, which is coming from the ductal system of the breast, but they have not invaded the basement membrane of the ducts. And if they invade the lobules, we have invasive lobular carcinoma, and if they invade the ductal system and go to the surrounding tissue, we have invasive ductal carcinoma. So what are the clinical features of lobular carcinoma in situ? So there are a few points that you have to know for your board examination. First of all, note that this is usually a asymptomatic cancer, and it is usually found incidentally on routine examination or mammography. But because of the fact that this cancer actually is not forming, usually is not forming a palpable mass, it is very difficult to diagnose, and diagnosis of this cancer is actually quite challenging. And if it is found on mammography, it does not create a characteristic features on the mammography. So you are not going to see any calcification within the structure of the cancer, and there are not going to be any visible changes in the mammography as well. So what are the diagnostic tools that we can use for lobular carcinoma in situ? We can use core needle biopsy, and this is the most common method in order to diagnose the lobular carcinoma in situ. And we have two main features that you have to know for your board examination. First of all, what you are going to see is a small monomorphic cells, and these are characteristic cells which are small. They have uniform structure, and they can expand the lobules and cause enlargement of the lobules because they are proliferating, because they are actually exerting pressure on the lobules. They can expand the lobules, and here in this picture you can see a very good example. And this is a lobule which as you can see is not invaded by the cancer cells, but within the lobular structure you can see that the cancer cells are actually pressing against the wall and myoepithelial cell and cause dilation of the lobules. Another point about this cancer, lobular carcinoma, is that because of a mutation, these cancer cells are actually lacking the E-cathedrin protein, and E-cathedrin protein is actually responsible to keep the cells tightly together. So these cancers do not have E-cathedrin, and as the result, the cancer cells are actually loosely connected together. And this is one of the main and distinguishing factors and features of lobular carcinoma in situ. Another tool that we can use is immunohistochemistry, and actually it is testing for E-cathedrin protein, and if the E-cathedrin protein is lost, this is characteristic for lobular carcinoma in situ. So here in this picture you can see the job of E-cathedrin. As you can see, in normal situation, when the cells are dividing, the E-cathedrin actually causes the tight attachment between two cells together. But when we do not have E-cathedrin, the cells are not going to be proliferated in the linear pattern, but they are actually stacking together and causes expansion, especially in case of lobular carcinoma, expansion in the lobular system. And E-cathedrin actually exists usually in the epithelial cells and causes the lining formation of the epithelium. So when we do not have E-cathedrin, we do not have linear formation of epithelial cells, and as the result they accumulate on the top of each other as a stock. So what are the types of lobular carcinoma in situ? We have two main types that you have to know for your board examination. The first type is classical type, which is the most common type of lobular carcinoma in situ. And in this case, you are going to see uniform cells that are resembling to each other. They are similar to each other. And these cells, because of lack of cadherin, they are not cohesive together, and they are actually filling the lobules again because of the fact that they do not have E-cadherin. Another type, we have pleomorphic lobular carcinoma in situ, and generally cells in pleomorphic lobular carcinoma in situ are larger and they are atypical cells. And these cells actually can resemble a high-grade ductal carcinoma in situ, and they have higher malignant potential. So we have two main differentials for lobular carcinoma in situ. The ductal carcinoma in situ can be very similar to this presentation, and ductal carcinoma in situ, unlike lobular carcinoma in situ, is a true precancerous condition, and it has a higher malignant potential in comparison to lobular carcinoma in situ. Another differential is atypical lobular hyperplasia. This is a less extensive proliferation of atypical lobular cells, and also note that atypical lobular hyperplasia can also be precursor for lobular carcinoma in situ. So what are the managements that we can use for lobular carcinoma in situ? The management is based on risk assessment and surveillance of the patient. So the first strategy is going to be observe the patient. So regular breast examination in order to detect any mass in the breast is going to be essential for this group of patients. Also, annual mammography is recommended for the patients, because with the mammography we can do early detection of any potential for invasive cancer. Again, remember that the lobular carcinoma in situ has potential to go to invasive ductal carcinoma and invasive lobular carcinoma. Also, we can have strategies in order to reduce the risk of malignancy. For example, tamoxifen and aromatase inhibitors can be used, and this is especially very important for the patients who are having a strong family history, so they are going to benefit the best from hormonal therapy. Another strategy for reducing the risk of malignancy is lifestyle modification. These group of patients are advised to have weight reduction, and also limiting the alcohol is going to be very beneficial for this group of patients. So also we have surgical options, and the surgical options that we have, first one is bilateral prophylactic mastectomy, and this is usually done in case of patients who are having high risk. For example, a patient who is having a strong family for breast cancer, or the patients who are having genetic predisposition, for example BRCA1 and BRCA2 mutation. Also we can have excisional biopsy, and this is usually done if the sampling has error in it. And note that in case of lobular carcinoma in situ, we have high occurrence of sampling error, or if there is a pleomorphic lobular carcinoma. So we have 4 key points for the exam. First of all, lobular carcinoma is not a cancer. This is a risk marker, and it is increasing the risk of malignancy, but it is not itself a true cancer. The second point is that the cancer cells in case of lobular carcinoma in situ do not have E-cadherin, and this is a distinguishing factor of lobular carcinoma in situ from ductal carcinoma in situ. And the management is usually surveillance, and it's focusing on surveillance. So we have observation, regular imaging, also risk reduction strategies like tamoxifen, aromatase inhibitor, and lifestyle modification. So the fourth point is that the pleomorphic lobular carcinoma in situ has more atypical cells and has more chance of progression to malignant cancer from the classic lobular carcinoma in situ. Thank you for watching.